So we all know what the knee looks like. I won't bore you with that. And different sprains. The reason I have this slide up is a lot of lay people, patients, will say, oh, it's just a sprain, but you and I both know that a sprain can be a complete tear. And sometimes your wording when you speak to the patient or speak to the coaches or speak to someone, and also on reports. Sometimes an MRI report will say sprain of ACL when they really mean to say a tear of the ACL, or a sprain of the anterior talofibular ligament when they really mean it's a mild sprain. So, you know, grade 1, you stretch the ligaments, don't tear. Grade 2, you tear, but you don't have a complete tear. And then grade 3 is completely torn. I've always found it interesting that a complete tear would almost always hurt less than a partial tear. The patients will, I've seen them, especially with the ulnar collateral ligaments, they'll want to keep playing. They'll have an acute tear and then they go out there and fumble the ball because they don't realize how bad the injury is, where the grade 2 folks are limping on the sidelines. So the big daddy, the one that we unfortunately see a lot of, and usually results in something operative, the ACL tears. Typically patients, right, they'll feel a pop or feel something give way. Some of the little girls won't necessarily feel that. I've had some of them tell me that they're running down the court and all of a sudden their legs just felt like spaghetti. That's it's amazing. Over the years you'll hear that. You know, it just felt like a noodle. Typically they'll have swelling within an hour. Usually can't go back to play. As an athletic trainer on the sidelines, you'll see the acute ones. I'll typically see, or not typically, but I'll oftentimes see the chronic ones. Someone he'll come in for knee pain and they'll tell me that, yeah, I popped my knee about 4 or 5 years ago and it's just been kind of giving me trouble ever since. He just wants to keep giving out, and the reason I'll see him is because the knee gave out and now they have a meniscus tear, or they'll have some type of arthritis or a loose body or something else that drives them to see the doctor. And the point of this is that ACLs have a lot of associated injuries, and chronic ACLs will have even more associated injuries. And there's kind of a debate of whether you should fix an acute ACL in everyone or wait it out and just fix them. You know, I shouldn't say it's even a debate, but patients, they'll say, well, I don't really want to have surgery, but should you really push them towards it? And the answer is definitely yes if they have an associated injury. And by that I mean a meniscal tear or some other ligamentous injury. So those patients usually do the best with surgery. Acute athletic patients, it's very, very difficult to go back to sports without an ACL. Occasionally you'll read about someone who doesn't have an ACL or who's able to play, but those are special people. Linemen, if you have a lineman in the middle of the season who tears his ACL, sometimes you can brace those up and get them back to play and fix it afterwards. But a skilled position is very difficult to get them back to play. So contact injury, those are the most common in men, in football, rugby, and also somewhat in soccer, where the knee gets struck on the side or struck in the front, resulting in a tear. Non-contact injuries from running, landing, and jumping, those are the most common in women. No one really knows why. There's lots of theories. Smaller size of the ACL, just physical size. There are some studies that show there's a bit smaller notch that the ACL lives in between the medial and lateral femoral condyles. With the wider hips, women have a little bit larger Q angle. There are some studies that implicate hormonal changes as the ligament will get a little bit softer in the month. But probably the real reason is landing. There's a lot of studies on the way women jump and land with their knees in a valgus position or landing a little bit more straight leg. There are numerous programs that have been instituted and followed. Do we have a program for that here?
Yeah, we're working on one right now, kind of seeing how it works.
And that's the problem with those is you don't want to do any harm, because there's been a few of these programs where patients have become injured. So there's a lot of, there's research and a lot of thought, but we want to be very careful that we don't do something where someone gets injured. And that's it. And footwear, this is so archaic, but I've worked with a guy up in Philadelphia named Joe Torg, and years ago, like in the 40s and 50s, there was a high incidence of ACL tears up there, and what they found out is, and he was one of the guys that led the charge on this, that they used to have cleats that were 3/4 of an inch long, and they found that when the foot was planted, twisting injuries, much higher incidence of ACL tears, and went to the 1/2-inch cleats, and it brought it way down. But you want to have traction, right? You don't want them slipping and falling, so it's a happy medium. Everyone here knows how to do the Lachman test? There's about 6 other tests. There was a world famous physician here at Lake Charles Memorial Hospital for years, and there was like 6 different tests you can do to learn how to make the diagnosis of an ACL tear, and they're all very difficult to do unless the patient is completely asleep. I mean, I'm a doctor. I've been doing this for 30 years. I spent a year up in Philadelphia with the guy Torg. He's the one who brought this Lachman test. He wrote the first article on it. Dr. Joe Lachman was a physician that Torg trained under, and Lachman never published anything, but Torg wrote the article and gave the test got its name from his mentor, Dr. Lachman. And it works, whether they're asleep or not. I mean, you can really, if you can get them to relax enough, you can really tell. If it's positive, it's 100% diagnostic. If it's not, sometimes there can be some problems with the patient relaxing, if the patient's a little too tense. I got a big old giant effusion, but I'm telling you, if you see them when it first happens, you get on them right then, before the swelling occurs, you can tell, right? Okay. So treatment, rehab, bracing, surgical treatment. I'm not going to bore you with that. I can't believe I misspelled failure. Spell check failed me. But I can tell you, when I was a younger physician, I was so gung-ho about fixing those ACLs and how great they're going to do. And I tell you, I'm a bit more negative on that. You'll see some folks do good, but I tell you, a lot of them don't do as well as we would like. Yes, they get back to play somewhat. Yes, the surgery can keep their knee from buckling on them, but do they ever reach the level they were before? Probably not. There's a significant loss of muscle mass. There's a lot of old literature that shows there are proprioceptive nerve endings in the ACL that have a feedback loop through the spinal cord. Without that, there is some definite loss of your quadriceps reaction and your quadriceps function.
Do you see more of a failure with allograft versus autograft?
Okay, when I say failure, though, I'm not talking necessarily about a re-rupture. Do they ever reach that potential they were before? To me, that's, yeah, they need to be aware that it's going to be difficult. Now, you don't want to put it on them so bad they don't try, but with a re-rupture failure is what you're talking about. Okay. There is varying literature on that, but in general, an allograft in a younger person has a higher incidence of failure. The numbers vary, but my personal experience is an allograft in a young person has a much higher incidence of failure. I think that's borne out probably by the experience in this community also. Now, would I do an allograft on a 40-year-old or a 50-year-old? Probably so. If you think about it, a lot of those allografts are coming from patients who were older, donors. They're coming from dead people, from donors. So there's not a ton of, luckily you're not getting a lot of 18-year-olds. So the ligaments, they're coming from older people, so they're not going to have the same robust quality that a younger adolescent or 18-year-old will have. And as far as the type of graft, it's whichever you want to do. Patella tendon is probably going to give you a little bit more, a better endpoint, but you're going to have to deal with the patellofemoral pain, which can be significant. Hamstring, muscle-wise, you're not going to really see a whole lot of difference. Taking the hamstring tendons really don't decrease the amount of the strength of flexion very much. You can tell with sensitive testing, but as far as the patients, most of them don't complain of that. There was a movement about 15 years ago. We're trying to get them back to play as soon as possible, which was one of the reasons allograft came into prominence. We were getting these people back within 4 months. Even Jerry Rice went back to play 2 months after an ACL, and he had a patella tendon graft. The problem isn't necessarily with carrying a graft by return to play too soon. The problem is with the associated injury. Something else happens. And in his case, he fractured his patella. So that's what happens if someone goes back to play too soon. Or they can tear the graft too. I mean, it can happen. Bracing afterwards, I usually don't use braces myself. Braces themselves can cause problems after an ACL tear. I mean, you're doing the surgery to put a new ACL in there. I think with proper rehab and proper recovery, they probably don't need it. Some patients want to wear a brace. If they want to wear a brace, I'll brace them up. A brace will not prevent a re-tear. PCL injuries, don't see too many of those isolated. What I wanted to say about PCLs, even though you can see them 20 to 30 years down the road, you can have arthritis, usually about the medial compartment of the knee. Fixing a PCL doesn't necessarily prevent that. Most common is a dashboard injury or when they fall on a flex foot with the foot and plantar flexion. Depending on how much sag they get is kind of the benchmark is whether or not they, well, you can see people with a lot of sag, and if they don't have symptoms, I wouldn't fix them. You can treat these. There's a fair amount of literature that shows you can treat these in an immobilizer, brace them up, and get the PCL to heal. And what the literature shows is on an MRI scan, you can see it healing. But my personal experience is those people still sag a lot. But if they don't have symptoms, let it rip. I don't want to talk about those. But we can. Y'all see a lot of MCLs. Okay. I would tell you this, let's talk about it. Isolated MCL tears don't need surgery. I mean, it's the rare case that I would want to operate on one of those, and usually you're going to regret it because they get a lot of stiffness. You'll see a few patients with MCLs who have a complete grade 3 tear, that even when it wraps around the back. After rehab, they'll heal, and they heal with a little bit of looseness. That's far better than healing with too much tightness. You operate on those, they get stiff, they'll lose extension, it's a mess. Adolescents, one thing you have to watch for is distal femur fractures. You can fool you. You can get a Salter-Harris 2 or 3 fracture. It'll give you looseness on the exam, and the same kind of injury, either a blow or some type of valgus stress. They'll have pain, they'll have laxity, they won't want to bear weight. They need an x-ray. Because Even some of the best will miss those. The meniscus, probably one of the most overtreated things we operate on in the adults. A lot of those can be treated conservatively with medications and injections. Just depends on how much symptoms they're having. Now, in athletes or young children, young kids and young adults, depending on their symptoms, I do my best to either discourage operating on them or preserve it if you can. The problem, as you might know, or you probably know with a meniscus, is it's like having a hangnail, and it's very difficult to get them to heal. The best way to get a meniscus to heal is when it's found in conjunction with an ACL. You do the ACL repair, you fix a meniscus, and there's something about the blood products inside the knee that help the meniscus heal. Otherwise, it can be very difficult to heal. There's 3 zones. There's a red-red zone on a tear, red-white zone, and a white-white zone. Anybody over 30 or 40, you're wasting your time trying to fix one. It's just not going to work. You're going to wind up going back and redoing it. So what you do is you braid it up at the tear, suture it together, and pray, right? The problem with taking out a meniscus is, yes, you're going to get rid of the symptoms for the next several years, but eventually the meniscus, because of the cushioning effect it has, and also it has a small amount of, it protects the knee from shearing forces. You're going to wind up with some arthritis. This is a fun one, probably one of my favorite things to treat. Patella dislocation. Patella sits inside the trochlear groove. This is a very normal looking patella. It's got a nice chevron shape, fits right into this groove, the trochlear groove. If you look, you can see the lateral patellofemoral ligament and then the medial patellofemoral ligament right here. It's thin and broad like a seat belt, keeps the patella centered. The femur and the quadriceps don't pull in the same line, so there's a lateral force on the patella with knee motion. In addition to the ligaments and the bone, you can have patients who don't really have much of a trochlear groove, like this one down here. I don't know how well that shows up, but the patient has a very flat trochlear groove and a very flat patella. That patella looks like it's already subluxed, doesn't it? This is that same normal one here. This is one that's dislocated laterally. So there's a rupture of the patellofemoral ligament, usually ruptures off the medial epicondyle. Occasionally you'll see one rupture up here at the patella, but most of the time it's ruptured down here. In this particular case, there's a large effusion and a loose body. See that right there? Probably a giant chunk of cartilage off of the patella right in here. There's also maybe a chunk off right in here at the lateral femoral condyle. So treatment, if you see one, sometimes it can be confusing whether it's subluxed or complete dislocation, but when you see a real dislocation, it's obvious. I mean, the knee is swollen up. They'll have tenderness on exam along the medial aspect of patella and medial femoral condyle. Patella apprehension can be dramatic. For those folks, if they have a large effusion, it's probably best to get the effusion off. They're going to need some x-rays or possibly some imaging to see if there's a loose body or some other associated damage inside the knee. To help with the swelling, well, there's all these different recovery phases, but rest, ice, compression, y'all know that. Anti-inflammatories can help. I think in this particular case, the compression wraps like the Game Ready or whatever the latest one that's in vogue can help out a lot. Y'all have those on site?
Some schools have them.
Yeah. I usually let these folks walk right away. I think that weight bearing with these injuries is really important. I think it keeps your quadriceps firing and keeps it going. If you make them non-weight bearing, it just becomes a mess. You'll get a ton of atrophy, and it makes it harder to recover your range of motion afterwards. So recovering the strength, working on your vastus medialis, your VMO, working on the gait pattern, introduce proprioceptive exercises as they recover, as the swelling goes down, as they begin to rehab. Bracing and taping, yeah, I think those help. The problem with it is, you know, you have to kind of gauge when to put the brace on. Otherwise, it's going to be painful if it's too early, or it won't fit down the road. So you have to kind of watch that. So for initial dislocators, usually I'll just leave them in a neomobilizer until they feel more comfortable with being outside the neomobilizer. As they progress through the range of motion, recovering the strength, add the brace. In these cases, stem and biofeedback can help out tremendous to get their quadriceps firing again. And eventually add on to their sports-related training. Recurrent dislocations. Now that's I said these are my favorite. This is like the ultimate favorite. These do great with surgery. I hate to say it like that, but they do. They do if you find one, find the right patient. So if I see someone who has an acute dislocation that has a loose body or a bad cartilage injury, that's an indication to do surgery just to take the loose body out. We'll go ahead and either fix those, or usually what I'll do is I'll fix them and reinforce their medial patellofemoral ligament. So there's different ways to treat this. You can do a bone realignment where you realign the tibiotubercle to alter the Q angle. That has really fell out of favor. There's a number of reasons. First of all, that thing hurts like crazy. You come down here, you chop off the tibiotubercle, you move it over and put a screw in there to hold it in place. And what you're doing is giving this patella tendon a more straight line, putting it in line with the quadriceps tendon right here. Now, it works, but you're highly unlikely to have someone have that done to both knees. I mean, they're not going to want it done to the other knee. Soft tissue procedures in the right patient who has normal trochlear groove anatomy work great. What you do is you simply go in here and you put a new ligament from the medial epicondyle to the patellum. In conjunction, let me back up. Here's the way I do it. First thing I'll do is I'll examine them while they're asleep, make sure the patella truly is popping out of place, scope the knee, we'll do a lateral release over here. And I don't necessarily believe that the lateral side tightens. I think that the lateral side probably is just the lateral side. But I'll do the release because I think that helps you center the patella when you do the medial repair. So I'll do an arthroscopic lateral release right here, release the lateral retinaculum and the lateral patellofemoral ligament. Then I'll do the open portion where I'll put the knee in about 30 degrees of flexion, and that holds that patella right in that trochlear groove, centers it, and that's where I tension the ligament. And this is pretty much what I do. I don't use such giant screws right here, this big screw, but basically I'll put a couple little, one little anchor here and one little anchor here, and I'll put a double ligament reconstruction in there. So for rehab for these patients, I usually make them wear a neomobilizer for about a week. I'll let them full weight bear. We used to leave it in the neomobilizer for 6 weeks, but pretty much what happened to me is the patients never really listened to me anyway. So they were taking their neomobilizer off, and so they were coming in at 2 weeks. Hey, my knee feels great. So I just quit telling them to wear it at 2 weeks. I pretty much let them do whatever with the rehab. As soon as they feel like it, I advance them as tolerated, and they do amazingly well. Rarely do I have a failure of these. Any questions on this one? This is like my favorite. Well, your graft size, you don't need a big graft, you know, because you're trying to reproduce this broad seatbelt-like graft, which is very difficult to sew into, I mean, from a mechanical standpoint. So what you want to do is kind of for an isometric point, I'm not sure I believe in those either, but they're the isometric areas right here on the medial epicondyle. The graft that I will use is an allograft. There's not near as much force, and you're putting a graft in there that's probably 20 times stronger than what's already in there. I'll take a posterior tibial tendon allograft and I'll split it. And that's how I do my repair. That's what I used to do the repair on that, or the reconstruction. They have some techniques that have you using these screws down here. Those can be pretty big. They're 7, 8, 9 millimeter screws. So it's a pretty big hole in your medial femoral condyle. I don't use those. I use a small little anchor that goes in, and I just suture the tendon down to the bone with that anchor, so the tendon doesn't go inside the bone, because you can really wall out a big hole doing it this particular way. And I suture the tendon, the graft, I'll suture to the MCL and the surrounding periosteum. It never fails, almost every year I'll see one or two players who will come in with a giant traumatic bursa. Does anyone have any questions on that medial patellofemoral ligament? I know y'all see these, because there ain't nothing you can do with these things except keep draining them. I'll drain them every Thursday before the game on Friday and let them go play, and they don't go away in athletes until they quit playing ball. These are traumatic bursa. You can see them over the elbow also, and also in addition to the knee. In older adults, it's a bit different. You usually don't see the traumatic, you'll see the chronic, in which the lining of the knee becomes much more thickened, and can be a little bit more difficult to deal with. Traumatic bursa, you aspirate them. As long as they quit playing, they'll just go away. But chronic in the adult patients, I try to discourage surgical treatment because it's a hassle for everybody and it can be expensive. And even with surgical treatment, they have about a 20% chance of recurrence, especially in the elbow. Now, if they get infected, that's different. They'll need to be drained like anything else. All right. Patellar tendonitis. I'm going to speed up a little bit. I think I'm running out of time. But so relative rest. I've actually had a fair amount of success with counterforce bracing, the little patella tendon straps. I think they seem to work pretty well. I've just had a patient from Leesville area who had a recalcitrant patella tendonitis, and if the area of tendonitis is in the right place, there's a nice little surgery you can do where you just go do arthroscopic and you remove it. It can be difficult to see the area though. You know, even though you see it on the MRI scan in real life, it can be very difficult to find. I see a lot of IT band syndrome. I'm sure y'all do too. Especially in the runners, running around track, running on a road that has a counter or canter. Usually it's the downside leg. Try to get them to reverse their direction that they run so the other side's down. can be very difficult to treat. I'll try all sorts of different shoes, icing, even injections can be very helpful. Anti-inflammatories. So one thing you have to watch out for with these is you can get bit if you keep treating really anything. If you're treating something and you're not getting a good response, you need to question whether you have a different diagnosis, like a stress fracture or a lateral meniscal tear. So sometimes that's when imaging becomes important, because you don't want to miss one of these guys right in here. That's osteosarcoma that I've had the unfortunate to see. So, questions?